Amit Thapa with brachial plexus injuries presentation. And feel free to put your questions in a question and answer chat box, and we will answer you in the moment of discussion. So Amit, please continue.
Thank you, Lukas. Well, is my screen visible?
Yeah, it's visible, yeah.
Yeah, thank you once again. And good evening from Nepal. And I am supposed to talk on management of brachial plexus injuries, a very good topic. And thank you, WFNS Education and Training Section, as well as my team at Peripheral Nerve Section, WFNS Committee. I have nothing commercial related to this presentation as a disclosure, even though some terms may be used, but that is only for purely educational and sharing experiences. And the photos I share are basically from the consent from the patient, and just to illustrate how the effects of these surgeries do lead to the patient's with. Well, brachial plexus injuries, as we all know, has a high medical, social, and health economic relevance. And once you give them their life back, when they're functionally reactive, the smile on their face is really enlightening. And this is how someone feels when he has lost his right hand and now he's able to write his name on a paper with his own pen. It gives them an immense sense of satisfaction. So what I feel that all the effort, all the challenges we do take up while we are managing these patients actually gives a lot of satisfaction at the end of the day when we have a good results. Sadly, brachial plexus injury repair is getting neglected because most of the surgeons, particularly neurosurgeons, feel that this is a very rare problem and too complicated to deal with. And the results are very unsatisfactory, particularly the initial ones. And the long duration of the surgery does not allow these surgeries to be done in our busy centers where the OR time is very limited. However, what I find from my experiences, as well as from the colleagues who had been a trailblazer in the world managing these patients, we find that these are basically a myth and apprehensions. And the newer advances and the systematic approaches have very improved outcomes. Well, the presentation of mine would not be able to completely cover all the aspects of brachial plexus injury repair, but I will definitely like to cover the basics and the most general aspects of this particular problem. Now, when we talk of the population data, in 1990s, there were many publications from North American population, which has found that the prevalence of the adult brachial plexus injury happens to be in 1.68 to 2.8%. And in polytrauma patients, nerve injuries can go as high as 2 to 4%. However, the hospital data are grossly inadequate, and that's why these population-based data need to be understood. Now, what is much more challenging is that most often these patients are young, healthy adults, which are ranging from 14 to 63 years old, and that's why this becomes a very important in the national role also. Well, children are also victim of brachial plexus injury. However, the most common injuries these sets of age group of patients have is an obstructive brachial plexus palsy, which can occur in 0.5 to as high as 4.6% per thousand live births. And the risk increases in newborns with increase in the gained birth weight, birth deliveries related issues like vacuum assisted, or in diabetic women whose baby's weight is more than 4.5 kgs. Well, brachial plexus injury is just not a simple nerve injuries, and this is because there are a lot of intricacies how that the nerve travels from its origin at the root, and then as it comes out of the axilla, and then it goes up to the limbs. Henceforth, it's all about the mechanism of injury, which actually has brought up this particular problem to the patient. It can be a fall with an outstretched hands or fall on the shoulder, even when the baby is coming out of the mother's womb. And because of which the mechanism of injury has been defined, has been classified as either high energy or a low energy or a complicated ones, which can be because of electrical, thermal, radial, or chemical injuries. And subsequently, the injuries it produces are of a varied type. Now, Lifford classification, which has been modified by Powers, actually has classified these types of etiology into 4 different types. Type 1 are the open injuries, either because of stabbing or low velocity gunshot or high velocity gunshot or blast injuries. Type 2s are closed, which can be at the level of different C5, C6 or C8T1 or C5 to T1, that is global, or panplexus injuries. Pathological and iatrogenic injuries can be iatrogenic or can be post-radiations or malignancies. And then type 4s are obstetric palsy. Now, one of the most important concept which we all need to understand is the preganglionic and the postganglionic injury, which has been defined whether the injury occurs proximal to the dorsal root ganglion. Because if that occurs, these types of preganglionic injury actually is an avulsion of the nerve root, which usually occurs from a hide injuries. And in these cases, there are no proximal stump. So there is no neuroma formation. That's why TNDLS is completely negative in these patients. And on MRI, one may find pseudomeningocele, and then clinically there will be denervation of the neck muscles. And then in the lower, if in case lower plexus like C8 and T1 roots are involved, and the patient may present with Horner signs with ptosis, meiosis, and anhidrosis. And a common test, clinical test, which is histamine test, which has been shown to be very sensitive for C5, C6 level, has been shown to be positive in generating a neurogenic response. That is the third phase of the triple sequential responses. However, the postganglionic injuries are those cases where the roots remain intact, and they're usually from tractions, and the pseudomeningoceles do not form in these patients. Now, how this is different is that the preganglionic injuries, the chances of spontaneous recovery is almost nil. And for these patients need to be taken up for the surgery as soon as possible whenever the diagnosis is made, unlike in the postganglionic where one can wait for the self-recovery in other types of injuries. Now, a very good classification which has actually illustrated how histologically the nerve is affected was brought up by Seddon in 1943, how he defined it as neuropraxia, axonotmesis, and neurotmesis, where neuropraxia, as we all know, is a transient block, is a physiological block where there is no anatomical damage to the nerve itself. However, in an axonotmesis, there's a lesion. However, the nerve is in continuity, so henceforth, the perineurium and the epineurium are intact, and henceforth axonotmesis do have some chances of recovery, but neurotmesis, where the nerve is completely divided, where the endoneurium and epineurium is also gone, in these cases, the spontaneous recovery chances are almost nil. So this was again defined by Sutherland into grade 1, 2, 3, 4, and 5. And subsequently, these define how we manage the cases. Now, the most complicated case of brachial plexus is the presentation. The presentations varies a lot, and henceforth, one must have a very, very high clinical suspicion whenever we are dealing with any patients of this sort, particularly in polytrauma patients, where I just mentioned that 2 to 4% patients can have a brachial plexus injury. So we should go for a thorough clinical examination, evaluating each of the movements in the upper limb, from shoulder to elbow to hands. We should understand that if there is no diagnosis, we're not going to treat these patients, because once the duration of surgical intervention is gone, the optimal time, then the recovery time is also not going to happen. Now, for each cases, what we are doing in our case is we are fulfilling this chart. This is also known as Molly-Diopnik chart, where we fill up the motor and the sensory function evaluation on the chart, and this helps us to identify the pattern of weakness, which also helps us to vocalize the extent of injury. With this, we also want to assess the donor nerves. We also want to assess the active and the passive range of motion. We want to rule out any quad injury, Hoffman tunnel sign to see whether regeneration is there or not. Vascular examination, because we need a perfused limb so as to have a neurotized limb. And then a fracture needs to be fixed first, because we need a stable limb so that the mobility can be put in later. And each case gets an EMG and NCV study followed by MRI, cervical, spine, and brachial plexus. So if in case we have any confusion in these patients, and we like to repeat the clinical examination at 2-week interval, and EMG and NCV is first done at between 2 to 3 weeks after injury and followed 3 to 4 weekly intervals. Now, EMG NCV is very helpful, because whenever we have any doubt that there's a preganglionic or proximal injury, or there is an axonotmesis or neurotmesis, or in other cases like neuropraxia, then this evaluation helps us to define the things. Now, MRI can see the nerves, and henceforth MRI can also see the lesions, as is seen in the right side of the picture, the presence of a pseudomeningocele, which can actually tells us that this is a preganglionic injury. Now, as I said earlier, depending upon what type of injury the patient has, we can decide as onto the management. So if in case patient has neuropraxia, then we can just wait and watch. As usually most of the patients will recover, that to a complete recovery can happen within 3 months of time. However, axonotmesis can be complete or partial. In the complete axonotmesis, again, the recovery chances are almost nil, and henceforth these patients do not have to wait for longer. But then we need to see if in case there's a mixed injury, then we have to wait for at least 3 months to have any improvement. Now, the problem is that the more we wait, the more we are losing the time for innovation or innovation, because it has been shown that though the initial concept was that we can wait till 12 months time, we have seen that if in case we are waiting even beyond 6 months time, that the muscle is actually losing its potential to regenerate. The motor end plates are denervating, and henceforth, even after having a good renovation, the motor end plates actually forget to fire properly, and this has been actually shown in the rat models, and henceforth we need to sometime tighter as to what would be a good window for renovation. Now, depending upon the time, we can time of injury and the patient when presents to us, we can define what type of management we can do. The most important or the most successful management has been the neural management, that is by using a nerve graft or a nerve transfer or a decompression surgery as soon as possible. But as it goes beyond 12 months to 18 months, then these types of nerve repairs or nerve transfers are not possible. Henceforth, we only can do for a decompression. Then comes the muscle, where in case where there's some initial contractures or there's a limitation of the range of movements, then we can use certain maneuvers. However, tendon transfer or pre-gracilis transfers are reserved for patients who have come back very late. And similarly, the bone maneuvers are actually started whenever there's a palsy for patients following after 1.5 to 2 years. So in a nutshell, there are a lot of things we can do with these patients. So conservative managements are basically reserved for only for patients with neuroprexias. So whenever the patient has neurotmesis and neurotmesis, we like to go for a nerve repair. So the first and foremost thing which we do in most of the patients is the neurolysis. Now, neurolysis is of two types, either external or internal neurolysis, which is reserved most often for the patients who are complaining for pain. And we like to see if the patient is having any neuroma, and depending upon the nerve action potential it generates across that neuroma, we can actually decide whether a simple neurolysis will work or not. Because the NAP will improve once the neurolysis is effective. However, if in case it is not effective, then we have to cut that neuroma and then do an end-to-end anastomosis. Now that leads to another type of management, that is the nerve repair, that is also known as end-to-end anastomosis. Now, we all know that the nerve can be mobilized by around 5 millimeter. So if in case any nerve which the defect is not more than 5 millimeter, we can do a direct end-to-end anastomosis. However, this has to be considered that the nerve can be stretched to a max of around 8 times, or rather 8%, because the moment we go stretching the nerve more than 16%, then the patients develop an arterial perfusion problem, and this nerve anastomosis actually scars and do not work later. So in the patients where the gap is more, we can actually use an autograft, which is usually used in an autologous manner. So here the major workhorse for our nerve injury repair is the sural nerve, which we actually can harvest from the lower limb. And then there are other autologous sources like vein and also the vein muscle complex, which has not been shown to be that much beneficial, but if in case the defect is large, then we can use it. However, this graft can work for distances over centimeters, but not beyond 50 to 60 centimeters. And of course, there are certain other grafts like collagen or coprolactone or polycholic acid grafts, and also allografts, so which can So these things can be actually used, and however, these comes with a cost, and they also can help you in regenerations. Now, the other thing which we'll be discussing more on this presentation are the nerve transfers, also known as neuritizations, which can be intraplexal. That is to say that if we are using the nerve grafts from the same plexus, and extraplexal if in case we are using grafts from the opposite side or from the outside that plexus, and supercharge end-to-end site transfers. So diarizotomy is a procedure which is reserved for pain management if in case patient has pain beyond 1 year of trauma, and functional pain, muscle and tendon transfer and arthrodesis are the talks which will be covered in the future topics presentations. Now, each of these methods, even though they have some indications, they have also limitations. So as I told about the nerve repair, if in case the nerve repair is done immediately, that is within 72 hours, then the contraction following a nerve injury is very less. But after 72 hours, almost the nerve shrinks, the nerve edges shrinks by 28%, and also the nerve ends actually gets blotted out. So that's why you have to cut them off before you attach it together. So that's why the nerve repair, if in case it is done early, it's better, but then if in case it's late, it's not going to be that much beneficial again. Similarly, in the nerve grafting, there's a donor mobility which is there, and that's why we have to consider the expandability of the donor nerves. Allograft requires a long duration of immunosuppression, and this comes with a cost. Conduits are only useful for a very short length, so example less than 3 centimeter, and they are used for those sensory nerves which are not located in non-critical areas. And similarly, there are other problems. So for the individualized treatment for any clean open injuries, we need to explore and immediately cut to repair it. And in clean incise injury, it's done the same. In contaminated open injuries, we should tag the nerve ends initially and then do a delayed repair as soon as the wound is healed. Depending upon the size of the gap, we can go ahead, as I said earlier, if in case the gap is less than 5 millimeter, then we can go for primary repair. Beyond this, we should go for an autograft and allograft. So nerve contour only helps in the shorter length. Now, acute exploration and early explorations, we have already talked about. So whenever we have a mixed type of injury, it's always better to wait so that any post-ganglionic injury, if in case it is associated with conditions like neuropraxia or with an incomplete or a partial axonotmesis, can recover by 3 months. However, if in case we do not see any subsequent recovery on clinical as well as EPS examination or electrophysiological examination, which are conducted every 3 to 4 weeks, then we should not wait. And we should go for surgery as soon as possible. And then in any other cases, we should not wait beyond 3 months. Now, Christian has actually in his presentation done a very good job by showing the various anatomical things. So whenever we are trying to repair or do any intervention at root and at trunk level, then the supraclavicular approach is the one. If in case we are opening the cords and the branches, and the infraclavicular approaches, and then in combined approaches, we go for the complete exposure. So the goal of intervention is fully functional hand, but we should understand this is not practically possible. So what we are trying to do is, first of all, establish the etiological, anatomical, morphological, functional, electrophysiological diagnosis. It is just like going on a war. We need to know the enemy to its completeness. And then we have to assess the extent of the damage. And then aim is to provide the elbow flexion extension, to stabilize the shoulder, and to provide abduction and external rotation, because that helps the patient in his day-to-day activities. Scapular stabilization will help him to raise his arm beyond his shoulder, and then a sensory function over the dorsum of the hand, and to decrease pain if to the maximum, and hand function if in case it is possible. However, it is very difficult because the regeneration starts from the spine itself, and henceforth it takes a very long time. And for the close traction injury, the philosophy used is almost similar as we have already discussed. So say, for example, if the patient is having a C5-6 injury, if in case it happens to be a preganglionic injury, like the case which we're talking about here, he had an axillary nerve injury, and we had done a neuratization of the nerve, which is in spinal accessory, and we could see a very good recovery. So this was an isolated injury of an axillary nerve involvement more. However, if in case it's a C5-6, then we can go for suprascapular and to spinal accessory nerve anastomosis for shoulder abduction, external rotation, and we can go for a double overleans for the neuratization of the musculocutaneous nerve, so as to able the patient for elbow flexion. And Somsack procedure can be used for allowing the patient for shoulder abductions. However, if in case it's a post-ganglionic injury, at that to an early phase, then we can go for a C5 lateral cord or upper trunk and neuratization, or C6 to posterior cord neuratization procedures. Similarly, these are the different other reports or the case reports where we have found very good results of these types of maneuver. So we can see certain movements even at the 4.5 months duration, and this is the patient after 9 months. You can see the patient can lift up weights, and also this patient is after 5 months, where you can see almost a near normal recovery happening at his shoulder and at his elbow flexion. We have over the time modified our approaches. So rather than going supraclavicularly, we are now going from a direct approach. So this is an approach for spinal accessory to axillary nerve neuratization. So spinal accessory nerve is used to neuratize the suprascapular nerve, which has been shown on the left side of the screen, and on the right side is the axillary nerve neuratization using the triceps branch. So this is how we do it after exposing these areas. Now for the C5, C6, 7 injuries, so we go again in similar manner. Only thing is that we do not have the the luxury of using the triceps branch. In those cases, we use the intercostal nerve to neuritize the axillary nerve. And for the elbow extension, we can use the medial pectoral or intercostal median nerve to neuritize the long head of the triceps or the nerve in anastomosis. However, if in case it's a post-ganglionic injury, then in addition to the C5 and C6 nerve root, which is available to us, we can use a C7 nerve root to neuritize the medial trunk and the posterior cord. And this is how it happens. So the patient has a very good recovery after a period of 12 months. And this is a improvement which is seen after 9 months. And this is another patient with improvement after 9 months. So this is another patient who had a very good recovery after, I think this is after 6 months of repair. Now, the special case may be a C81 injury where the patient is young and operated early. Then we can use an ipsilateral or contralateral C7 to lower trunk to medial nerve to medial cord neurotization procedure. And if in case the patient comes late, then we can go for a brachial nerve to median and ulnar nerve, as well as nerve to brachial and supinator to posterior nerve. So this is a case of a complete or a total C5T1 injury. So we have done a lot of neurotization from contralateral C7 to intercostal. So in these cases, this is all an extra plexural repair because there is nothing inside the plexus which can give you a good donor. So in those cases, we can use a combination of a contralateral C7 to multiple intercostals to neurotize to achieve the elbow flexion, elbow extension, and of course, shoulder reanimination. So this is how we open up the intercostal nerve and then try to neurotize this. This is suprascapular neurotization. Now, someone may say that, okay, we see these pictures, patients are moving the limbs, but then this is just a cosmetic benefit. However, there have been a lot of studies on this. This was a publication in 2017 where they have found that the overlying nerve transfer and similar procedures are highly cost-effective strategies for storing elbow flexion function and improving the QOL. And so the data is there that it gives a help. The thing which has been upcoming in the last 2 decades has been a supercharged end-to-side transfer. Now, what we have been doing till date had been an end-to-end transfer, which is a direct anastomosis. But the supercharged nerve transfers are these days used for as a booster surgeries. Whenever we do not see a very good benefit or an optimal outcome of the patients, then we can use a donor nerve fascicle and then try to innovate the already recipient nerve and just produce a small crush distal to the anastomosis so that that particular crush injury can incite the nerve growth into it. So this is how the sets work, and it has been shown to be very useful. A word about DRES or dresotomy, and this is a procedure which is done for pain, basically in those patients who have a preganglionic injury, as seen on the photograph in the screen. So you can see there's an absence of the rootlet before the lesion. And then after the lesion, you can see there is a depth or a mark which has been created in the DRES area. So this procedure has been shown to be very beneficial. And this has been now been delivered in various manners. So what we are doing is a microsurgical and radiofrequency lesioning. There are reports where the people have used lasers as well as ultrasound based ablation technologies also. Now, this being a very long time taking surgery, it needs a lot of ergonomics. Otherwise, after going for a surgery for this duration, one may get tired and cannot do it. So just to share experiences of more than around 250 patients with us, most of the patients approached with us had been a patient of neurootmesis followed by axonotmesis, and we found that the outcome actually depends upon the severity and the location of the injury, the timing of the surgery, age and overall health of the patients, and the experience and the skill of the surgeons, as in any other literature which has been published. So in overall, we have 50 to 95% improvement, and the good recovery rate had been 76% as when we combine all the patients. And none of the patients have died in our series, and there have been 2 cases with minor wound infections. And this is a very important slide which I like to show to all my colleagues. The delay of surgical intervention actually affects the outcome. Henceforth, it is very important to act on timely in these patients. Besides the brachial plexus injury, we also have a lot of peripheral nerve injuries, and these are the patients with the radial nerve, median nerve, and all sort of peripheral nerve injuries, which has got benefited out of this. This was a case where we, the plastic surgeons, orthopedicians, have worked together. This is a patient of a crush injury, which is a completely limp or rather a chopped off arm, and the patient is now able to feel his arm and is able to move it. This is almost after a year of intervention. So sharing with you small pearls to improve results. Early diagnosis and proper work is very important. Time is the key. One have to remember pre-chronic, we do not wait more than 3 weeks. This is just to give some time for the neuroplexic injury to improve. Post-ganglionic injury, if in case it has to recover, it will recover within 3 months. After that, we have to intervene. So the best to intervene in the adults within 12 months of the time, and in infants 18 months of the time can be allowed. However, aim of this surgery should be well defined and should be well discussed. Patients should not be over expected or of the expectant of the outcomes sometimes, which do happens. And the stage surgery, whenever we are planning, we should intervene rather than wait. So best outcome with the surgical repair is achieved by dedicated nerve repair. We focus exposure, good donors, and distal anastomosis using electrophysiological techniques at each level, tensionless anastomosis. So there should be a sort of redundancy at the level of anastomotic line. Direct cooptation is very, very important, and we try to avoid graft as much as possible by mobilizing the nerve. However, mobilizing a nerve too much is also detrimental, so that's why we have to be careful about the gap. And the transfer surgery as early as possible in the stage surgery we already discussed. So microsurgery technique, we also know that it has to be an epidural stitch. Interfascicular stitches are also being applied, but then it can cause a lot of scarring. So epidural is the one we try to do it as much as possible. And then, so we try to do glue anastomosis like this, is a drip and drip technique by which the glue is posed. However, in countries, low middle income countries like ours, glues are not very readily available. So we are trying to going to for the microanastomosis as much as possible. And the best outcome is also achieved by selecting good donors. So, and the two which have a similar neuromuscular units, and re-innovate the recipient graft as close to the target muscles or as close to the end plate as much as possible. And whenever using a graft, the short nerve graft less than 10 centimeters better. If in case the gap is more than 10 centimeters, you should always be using a vascularized nerve graft, and the graft should be almost 20% more. Other than that is the supervised physiotherapy. So one should always go for a supervised physiotherapy whenever being allowed to, because patients actually get demotivated if they do not get any outcome within 3 to 6 months. And so these patients needs to be counseled at the timely and always have to have a supervised physiotherapy. And this is what we are following here. And beside that, we should always be very much vigilant about the signs of recovery. So if in case the recovery is not occurring within 6 months, even not being seen on EMG or NCD study after intervention, we should plan a second stage of salvage surgery if in case it is the response is not acceptable. The most important thing which I have found after starting the practice in my country had been to create a social awareness. There is a innate sort of belief in the community that these types of surgeries do not help, and hence what we need to have to spread the awareness about these type of reconstructive neurosurgery, and also to standardizing the indications and the facilities. And the most important is to gather the evidences from research which is ongoing in the country. So to conclude, we should always have a high clinical suspicion, and examination should be the most important task of any clinics which is managing the brachial plexus injury. So current trend is early repair and always as distal as preferred. Some treatment should be offered, and these patients, if in case they have a primary failure, should be re-explored. The benefit of the brachial plexus repair, which we have found, as in any other literature in the world, depends upon the factors like the type of injury, timing of intervention, surgical techniques, and post-operative follow-up. And whatever good outcome in our patients we have seen has happened in those patients who have came early and who have continued in follow-up. So dedicated follow-up is very, very important. So we do counsel the patient that this is just not a one-time investment. They have to be continue on the follow-up, because we know that the cortical training is very, very important in these patients to achieve. And then standardized protocols and the newer tested options, they do provide better alternative. And of course, the lack of awareness and the socioeconomic reasons are something which we need to fight for, so as to allow our patients to have an early intervention as soon as possible. I would definitely like to acknowledge the mentors and the seniors in this field who have actually done a lot of good things, and I'm blessed to have interacted with them and my team who had been working behind the scenes, working for my patients and giving the best to the patients. I'd like to acknowledge the World Federation of Neurological Societies for giving us this opportunity, and thank you all for the patience listening. I'm available for any queries. And before I depart, I would like to invite you all for the 11th National Conference of Nepalese Society of Neurosurgeons, which is happening in the eastern part of Nepal this time from 14th to 16th November 2024. Thank you.
Thank you, Amit. Excellent presentation. Very informative and very important for the raising awareness about the importance of treatment brachial plexus injuries. Debora, please continue with this moderation now. And Mehmet, what is the plan?